Hi, I'm Bob Kamei, Vice Dean of Education at Duke-NUS Graduate Medical School and co-director of the Academic Medicine Education Institute, or AMEI. I'm really delighted to have with me today an old friend, Professor Bob Wachter from USCF, to share with us some insights on how collaborative teamwork and interprofessional learning can really enhance patient safety. So, Bob, you're known as one of the pioneers in hospital medicine and patient safety. Maybe you can give us some of the insights on the culture of medicine and how that impacts on patient safety.
Culture is dominant. It's a critical issue. I think when we started this, I don't think we fully appreciated the role of culture. I didn't learn anything about culture in my training, and I'm not sure you did either. It was sort of a foreign concept to us. We thought that if care was unsafe, that we could fix that with things like checklists and computer systems and standard procedures. And it turns out that culture is extraordinarily important. Culture is basically the way we do things around here, and you can't figure out what the culture is from reading the policies or the manuals. You have to actually understand the nature of the work.
Well, we've spent billions of dollars developing technologies and new devices and computer systems and all sorts of things to try to overcome some of the human errors that are inevitable. But hasn't those things helped at all? Hasn't those eliminated our patient safety problem?
It's actually a complex question. We had this notion that progress is good, technology is good. That's a logical notion. It turns out to be true with our smartphone, and it turns out to be true with a lot of parts of our cars. But in medicine works a little bit differently. It turns out that new technology has not only not made healthcare safer, it's actually made it less safe. Before there were MRI scanners, we didn't have cases, and now fatal cases, of patients getting harmed from magnets and in the MRI scanner. When patients come to the intensive care unit now, they are often on 10 different intravenous medications, going through 2 or 3 different intravenous pumps, on a sophisticated mechanical ventilator, getting dialysis by the bedside. These are breathtaking technologies. They're actually good things. But what we didn't recognize was each of these technologies adds a level of complexity to care that, if you don't do anything about it, makes care less safe. There are more error chances with each new technology than there were before them. So one of the things that we tried to learn from other industries, and the lessons are imperfect because medicine is very different than, for example, aviation. But when you do look at aviation, you look at the cockpit of a modern jetliner. It is an unbelievably sophisticated amount of technology. And yet they have figured out how to take all of these thousands, if not millions, of data inputs and simplify it so that the pilots only see the things that they need to see. And the rest of it is just working in the background, making sure the plane is flying correctly. We've not yet done that in medicine. So what we have in medicine is, if you are the equivalent of the pilot in the intensive care unit, you are having things pinging you constantly. You know, alarms are going off and bells are going off, and there are blips on the EKG screen. And lo and behold, humans don't have the capacity to keep all of that stuff straight. It's too much data. And we've not yet woven it together in a way the way they have in other complex industries, so that people use the data that they need, but the stuff that they don't need, or the things that are just humming along and are going fine, they don't see.
Thinking about the airplane analogy that you said, airplanes have co-pilots. So, and when you talk about the no longer talking to the radiologist, is it because there's been some sort of lessening of these teams, or breakdown of communications between different physicians, or what?
I think that we have learned that medicine is a team sport. And again, as I think about the training that I gave to our residents, we didn't think that way. We all felt like we were different tribes, and the doctors trained with other doctors, and the nurses trained with other nurses. And then at the end of the training, we threw them all together, and it was like we put them in a blender, but they didn't know how to talk to each other. We never taught them that the game is actually completely a team sport, and not just between the docs and the nurses, but also involving families and involving patients. So that involves a type of training that we never did before. Because not only do we not learn about teamwork and learn teamwork skills, and it turns out there are skills, and partly they can be trained, but we were kind of on top of the pedestal. And so it seemed pretty attractive to many of us to say, I am the doctor, everyone else is sort of operating down here, I give orders, people run around and follow my orders, and I think many of us got seduced by that, didn't realize how extraordinarily dangerous that is.
But don't you need a pilot? Don't you need that?
Well, I think that's part of the great challenge that we have now, which is to say that absolutely all teams need leaders. And as we teach teamwork to our trainees, for example, we don't try to teach the idea that everybody's equal and we should all sort of have a group hug and sing together. That sounds warm and fuzzy, but I'll tell you right now, if my heart stops right now, I want someone to run my code. I don't want everybody to be equal. And I think that it is important to teach, when you're teaching teamwork, you also have to teach about leadership. And in many circumstances, the physician will be the leader and they need to know how to do that. But there will be other circumstances where the physician will not be the leader and shouldn't be the leader. The leader should be the nurse or the case manager. The leadership should be fluid and really should be based on the circumstance, and in that moment, in whatever the problem is, it should be the most appropriate person. I think for physicians, we didn't recognize that if the hierarchies were that steep, if the physician is always up here and everyone's running around following orders, this issue of culture that no one will speak up when the leader is up there and we're all down here, it gets in the way of safety. When every physician has his or her own preferences about the way they want their world set up, it creates this level of chaos beneath them. So this issue of teamwork involves the team agreeing on a level of standardization when that's appropriate. Now, patients are not airplanes, and some degree of flexibility is very important. And also a recognition that medicine has become so extraordinarily complex that the physician can't do everything him or herself. The old notion 30 years ago, 40 years ago, which is, I know everything, it's all between my ears, I will be the font of all knowledge, everybody just follows around what I tell them, is ridiculous now, because I can't know everything. I have to depend on the pharmacist or on the nurse to get the job done. And so it's our obligation as educators to figure that out, to train, not to train doctors to not be leaders. It's important that leadership skill is just as important as teamwork skill. But one of the things leaders do is they recognize that this is a circumstance that needs very powerful, in some ways dominant leadership, because we have a problem to solve right now. The patient is coding, we got to do something. It's not a time for democracy or a vote. But most of the times, if that's the way I approach every problem, we can't create an environment where people feel comfortable speaking up to me, where we can problem solve together as a team. And so good leadership is not necessarily all flat in terms of the hierarchy, nor is it necessarily all very vertical where I'm barking orders. It's flexible. And good leaders figure that out, and one of our obligations as teachers is to teach people to figure that out in the given circumstances.
You also describe, with all of this teamwork imperative, that people have to be able to communicate well, but physicians and nurses and other health professionals probably have different languages that they speak, and the respect that gets transmitted between the different specialties also has been discussed in lots of papers as being a problem where people do feel disrespected, and that breaks down communication and teamwork.
Yeah, no, I think that's right. I think that we were trained in some ways to speak different languages, that physicians often were not trained to respect the other professions. What we came to find in the early years of patient safety was nurses often communicate in stories. And a nurse will call a doctor up and say, "Doctor," and begin describing a patient in the way that's comfortable for nurses to describe patients, because nurses learn a certain way of describing patients. They tend to be stories, they tend to involve the social context. It's a very valuable way of thinking about the world, but that's not the way the doctor wanted the information. The doctor often wants to hear what's going on, what's changed, what are you worried about, what would you like me to do? And so for nurses, one of the challenges was learning to communicate in that way. And the same thing is true, we're learning in the operating room how to start a case. So in the old days, the nurses and the other people would set the case up, the doctor would swoop in, the case would start. And we've learned that that's extraordinarily dangerous, because in other safer industries, they would never do anything that complex without stopping before they start, everybody taking a deep breath, introducing themselves to each other, which in some ways liberates people to recognize, yes, we're all part of a team together. It's okay if I speak up if something seems wrong. Go through a checklist to be sure that we have the right equipment, we're doing the right procedure on the right patient. And so in the beginning, a lot of surgeons said, this seems kind of silly, going through a checklist, introducing myself. And it's actually been studied when they introduced the surgical checklist, it has markedly lowered the mortality rate of patients undergoing surgery. Even with that, when a study was done a couple of years ago and they asked surgeons, what do you think of this idea of using a checklist, doing a timeout before the surgery starts? About half the surgeons said, I still think this is kind of dumb, I don't want to do it. Then they asked the same surgeons, if you were having surgery, would you want your surgeon to use the timeout and use the checklist? And about 95% of the surgeons say, yes, I would want my surgeon to do it, even though I'm not sure I fully buy into it. So
I don't need it.
I don't need it because I'm pretty flawless myself, but for that other person, yeah, he or she might need it. So we've got a lot of work to do. We just have to figure this out. It's, one of the things I've learned in doing this work in patient safety is it's always more complicated than you think. We always come in and think we have the silver bullet. It's either it's a checklist, it's a new policy, it's a computer, it's all of it. And there's also this squeezing balloons phenomenon that when you fix one thing, something pops out the other end. We shorten the number of hours that residents work. That's good. I remember falling asleep driving home a few times when I was a resident, but we've now doubled the number of handoffs. So we now have to think of doing handoffs better. We have these computer systems. That's great, but we're now seeing new errors caused by computer systems. In the US now, there's far better and more supervision of trainees than there ever was before. I think that's great and I think it's healthy, but now we're hitting a concern that we're graduating trainees from their training without having given them the independence that they need at the end of their training to go out and be on their own.
But what other aspects of education that we should be thinking about to make our patients safer?
Well, I think back on my education and I learned precisely nothing about systems thinking, about cognitive psychology, about human factors, about how one has to think about systems. And there is a science there in the same way there's a science about genetics. I think we've neglected to teach that science. And so part of the art of teaching this work is, yes, there's a body of knowledge, and it's actually a very exciting, interesting, complex body of knowledge. A lot of it does not come from medicine. It comes from people who've studied aviation or the nuclear power industry or cognition and how humans think and how humans make errors and cognitive biases. It's a very rich, interesting body of literature, and it's, I believe, no less important that our trainees learn it than that they learn biochemistry and molecular biology. So we have to teach that. The second reason I think teaching it is so important is that we also have to teach our trainees that the great doctor of the future is someone who not only is a terrific doctor treating the individual patient, but also someone who instinctively thinks about the system of care that they work in and knows how to and cares deeply about improving that system over time. So I think the training of students, residents, and others is not only a body of knowledge that they need to know, but also a new mindset that this is actually part of my professional responsibility, and this is what a good doctor of the future looks like, not just that old style of individual patients, but making the system work better. A lot of the field of patient safety and quality is in projects, is in, okay, I've identified a system that doesn't work. The way we discharge patients doesn't work. The process of ordering a medication has about 100 steps in it, and the chances that all the steps are going to be correct in any given patient is really, really small. We have to make that system better, clean it up. So we have to figure out a way of teaching our trainees how to do that. And I don't think there's any substitute for actually giving them a set of problems to work on. So what we're now doing at UCSF is our students and our residents, part of their curriculum is not only a foundational training in safety and quality, but actually taking a problem, of a clinical area that doesn't work well or we've identified as being unsafe because we saw an error, and sort of setting them loose on it with mentorship. And they organize the committees and they develop the processes to try to fix it, and they try to implement the solutions, and they find that it hits a political wall and they say, that didn't work, let me try something else. I think the only way to learn that is experiential, like everything else in medicine, and you have to build in those experiences. That probably is the hardest thing of all. I mean, everything else is hard, but teaching the foundational curriculum is relatively easy. Changing the nature of the wards and what they experience, that's pretty hard. But trying to figure out how to build in these experiences is very tricky, partially just logistically, like finding the time for them to go to a number of committee meetings in a row and participate in a meaningful way. One of the things that we've done in our residency is we've built in time. They have a 2-week safety curriculum, so a safety quality curriculum. They get a foundational part of it, and then we do a group project. So a year, a class will pick a project. We're going to improve the discharge process this year, or we're going to improve the way we communicate with primary care doctors, or the way we manage certain laboratory tests. And it will weave itself through the entire year, so when interns come on to their 2 weeks, they'll participate in a chunk of it. And then as a group at the end, we sort of roll it all out and celebrate all of their participation in it. I think that's actually more manageable than the idea that every single one of them is going to run a project and then working out logistics. That's really tricky.
Well, Bob, you've given me a number of great ideas.
Oh, good.
and really, I think, emphasized the importance of all of this for really expanding the role of the traditional role of the physician, but to really incorporate this as a responsibility for the new age physician. So it's been such a pleasure to have you here in Singapore with us, and thank you for sharing.